Welcome to Roadmap to Residency. Hello everyone, I am Avi. Welcome to our Club 250 Mass Mega Sessions. We will be running through some questions with you guys to help you on a journey to 250. Currently we're in our psychiatry module, and this video is all about substance use disorders. So here we have, which of the following best characterizes the primary feature of alcohol use disorder in this patient? So, a 40-year-old male presents to the clinic with concerns about his alcohol consumption. He reports a pattern of daily alcohol intake for the past 6 months and acknowledges being unable to cut down despite repeated efforts. The patient frequently experiences a strong craving for alcohol and has noticed a tolerance to its effects, needing increasing amounts to achieve the desired level of intoxication. He has a history of neglecting responsibilities at work and strained relationships due to his drinking. Physical examination reveals signs of liver dysfunction, which of the following best characterizes the primary features of alcohol use disorder in this patient. Limited alcohol consumption without adverse consequences, episodic binge drinking with subsequent remorse, daily alcohol intake, inability to cut down, tolerance, and impaired functioning, social drinking without craving or tolerance, occasional alcohol use without signs of liver dysfunction. So daily alcohol intake, inability to cut down, and tolerance and impaired functioning are the primary features of alcohol use disorders in this patient, which include a problematic pattern of alcohol use leading to clinically significant impairment or distress. Now, this can manifest as daily alcohol intake and inability to cut down despite efforts. Other options like limited alcohol consumption without adverse consequences does not meet the criteria of AUD, which requires impairment or distress. Episodic binge drinking with subsequent remorse. While binge drinking is a potential pattern seen in AUD, the presence of remorse alone does not fulfill the criteria for AUD. Social drinking without craving or tolerance. The absence of craving and tolerance makes this less indicative of AUD. Occasional alcohol use without signs of liver dysfunction suggests a more severe pattern of alcohol use than occasional drinking. Now, talking about the substance use disorder. So these are the maladaptive pattern of substance use involving more than two of the following in the last 1 year. Maybe tolerance, withdrawal, intense or distracting cravings, using more or longer than intended, persistent desire but inability to cut down, time-consuming substance, accusation, use or recovery, impaired functioning at work, school, or home, social or interpersonal conflicts, reduced recreational activities, more than one episode of use involving danger, example unsafe sex, driving while impaired, continued use despite awareness of harm. Now, in the case of appropriate medical treatment with prescribed medications, example opioid analgesics, sedatives, or stimulants, symptoms of tolerance and withdrawal do not indicate a substance use disorder. No. So if the patient have been prescribed opioid analgesics for a chronic period of time, and now the person is showing the symptoms of tolerance or withdrawal, then that is not a substance use disorder. Okay, that is something related to the medication tolerance or medication withdrawal symptoms. So there are some different sort of substance use disorder which are commonly asked in the examination. So depressants is one of the class of the substance uses. Now, there may be not specific, if there is intoxication, there may be some non-specific symptoms like mood elevation and decreased anxiety, sedation, behavioral disinhibition, and respiratory depression. These symptoms are common in all the depressants substance use disorder. And in case of withdrawal of the depressants, there may be general symptoms related to the depressions like anxiety, tremor, seizures, and insomnia. Now, talking about the individual drugs, alcohol, the mechanism is via the GABA A receptor positive allosteric modulator. So it acts on the GABA A receptor and causes, in case of intoxication, the patient has emotional liability, slurred speech, ataxia, coma, blackouts. Okay, AST value is 2 times the ALT value, and treatment is supported. That is IV fluids and antiemetics. And if there is withdrawal, then we treat that by longer acting benzodiazepines. Now, in case of barbiturates, it also acts on the GABA A receptors. But the thing with barbiturates is that it has a low safety margin. Okay, so if there is barbiturate intoxication, there is marked respiratory depression, which can also lead to the death of the patient. So treatment is via the symptomatic management, example, assist respiration or increase the BP, or you may have to intubate the patient. In case of withdrawal, there is a delirium or life-threatening cardiovascular collapse. Benzodiazepine also acts on the GABA A receptor, but there is a greater safety margin. The patient may show ataxia, minor respiratory depression, and treatment is via the benzodiazepine receptor antagonist, that is flumazenil. In case of withdrawal, the person may show symptoms like seizures, sleep disturbance, and depression. Opioids acts on the opioid receptor, okay, and it is a receptor modulator. The activation of mu receptors on the opioid causes the prototype effects of pupillary constriction, okay. Now this is sometimes a very differentiating feature. Pupillary constriction happens in opioids or pinpoint pupils. Decreased GI mortality, respiratory and CNS depression, euphoria, decreased gag reflex, seizures, and most common cause of drug overdose death is opioids. Overdose treatment is by the naloxone. Now, dilated pupils, diarrhea, flu-like symptoms, rhinorrhea, yawning, nausea, sweat, piloerection, lacrimation are some of the symptoms of withdrawal of opioids. And we treat the withdrawal by symptomatic management, methadone and buprenorphine. Inhalants, okay, enhance the GABA signaling and they cause disinhibition, euphoria, slurred speech, ataxia, disorientation, okay. And in case of withdrawal, there is again sleep disturbance and headache. Now there are some stimulants. Okay, now stimulants happen some in case of intoxication. There are some non-specific symptoms which are common to all these stimulants. There may be mood elevation, decreased appetite, psychomotor agitation, insomnia, cardiac arrhythmias, tachycardia, or anxiety. And in case of withdrawal, there may be some common symptoms like crash, post-use crash, including depression, lethargy, increased appetite, sleep disturbance, and vivid nightmares. Amphetamines induces the reversal of monoamine transporters like VMAT. Okay, VMAT is very commonly tested. And in case of intoxication, it causes euphoria, grandiosity, mydriasis, prolonged wakefulness, hyperalertness, hypertension, paranoia, fever, skin excoriations with methamphetamine. These are some of the clinical vignette sort of substance sentences that are used in the question, and it may be very helpful to you to diagnose amphetamine intoxication. Okay, there's skin correlations with methamphetamine use. Severe cardiac arrest and seizures can happen. The treatment is via the benzodiazepines for agitation and seizures. Now, talking about the alcohol use disorder, which is diagnosed using the criteria of substance use disorder, and the complications are commonly tested. And these are the vitamin B1 thiamine deficiency, alcoholic cirrhosis, hepatitis, pancreatitis, peripheral neuropathy, testicular atrophy. Okay, the treatment is with naltrexone. Okay, naltrexone reduces the cravings. Acamprosate we cannot use in renal failure sort of patients, but in normal patients we generally go with acamprosate. Disulfiram to condition the patient to abstain from the alcohol use, and support groups such as alcoholics anonymous are helpful in sustaining the abstinence. So disulfiram causes the disulfiram reaction. If you are taking disulfiram and then you drink alcohol, then you will have a very disastering symptoms. Okay, that will be very difficult for the patient. So you just say you can tell that you are scaring the patient to use alcohol. Due to the scare and fear, the patient will not use alcohol. You are abstaining the patient from using alcohol. Talking about the Wernicke-Korsakoff syndrome, the results from vitamin B1 deficiency symptoms can be precipitated by administering the dextrose before vitamin B1. Um, Triad of confusion, ophthalmoplegia, and ataxia may progress to irreversible memory loss and confabulation of memory plus personality change. Treatment is by IV vitamin B1 before dextrose. So first you give IV vitamin B1 and then you supplement the patient with dextrose. Now let's do one more question here. So which of the following best characterizes the primary features of opioid use disorder in this patient? A 28-year-old woman presents to the emergency department with complaints of severe abdominal pain and nausea. She reports a history of escalating opioid use over the past year, initially starting with prescription painkillers for a legitimate medical condition. And despite completing the prescribed course, she continued seeking opioids through various sources. For the patient acknowledges the unsuccessful attempts to cut down and experiences physical discomfort, including abdominal cramping, when not using opioids. Now, she denies using opioids for recreational purposes, but admits to an increasing preoccupation with obtaining and using them. Now, which of the following best characterizes the primary features of opioid use disorder in this patient? Limited and controlled use of opioids for medical reasons, no. Recreational use without physical discomfort or cessation. Escalating use, unsuccessful attempts to cut down, and physical discomfort when not using. Infrequent use without preoccupational cravings. Absence of withdrawal symptoms when not using opioids. Okay, so here the answer is escalating use, unsuccessful attempts to cut down on physical discomfort when not using. Yep. So here is the explanation. The primary features of opioid use disorder include a problematic pattern of opioid use leading to clinical significant impairment or distress. So this can manifest as escalating use, unsuccessful attempts to cut down, and the development of withdrawal symptoms when not using. Now, a 22-year-old college girl student is brought to the clinic by his roommate due to concern about changes in behavior. The roommate reports that over the past several months, the patient has been staying awake for days at a time, engaging in frenetic and disorganized activities, and frequently talking about grandiose plans and ideas. The patient admits to using cocaine regularly to enhance his academic performance and maintain high energy levels. He has experienced multiple failed attempts to cut down on his cocaine use and acknowledges a persistent desire to use the substance despite negative consequences. Physical examination reveals dilated pupils, elevated blood pressure, and tachycardia. Which of the following best characterizes the primary features of stimulant use disorder in this patient? Limited and controlled use of stimulants for academic purposes, recreational use without negative consequences, the regular use leading to impairment functioning, unsuccessful attempts to cut down, and persistent desire to use. So, choice C is the correct answer. We have one more question here. So, which of the following characterizes the withdrawal symptoms observed in this patient? A 30-year-old man with a history of chronic alcohol use abruptly stops drinking. Within 6 to 8 hours, he becomes agitated, anxious, and experiences tremors. He also complains of nausea, vomiting, and abdominal pain. And on the second day of abstinence, he develops hallucinations, including visual distortion, tactile sensation of insects crawling on his skin. The patient is disoriented to time and place. Blood pressure and heart rate are elevated and he is diaphoretic. Which of the following best characterizes the withdrawal symptoms observed in this patient? Hypertension and tachycardia, sedation and respiratory depression, agitation, tremors, hallucinations and autonomic hyperactivity, muscle cramps and constipation, hypotension and lethargy. So agitation, tremors, hallucinations, and autonomic hyperactivity. The withdrawal symptoms described uh, are characteristic of alcohol withdrawal symptom. Thank you for watching. Keep studying.